Okay, sir. So, me. आइए सर प्लीज
I like to thank Dr. Ashish sir. He has been so kind to speak so good about me, and that's not the case, I suppose. Uh, so he holds much more experience than me as far as joints and robotics are concerned. But I'll try to do whatever best is possible at my end, and maybe he's going to put in wherever I'm wrong. I hope so, sir. So I think if everybody can come in front, those whoever are here. Yes, that's fine. Uh, so we are going to start with a sawbone session on, we'll consider this as a routine varus knee, because that's the thing which is most common. And I think everybody goes with a routine midline incision medial parapatellar approach. Is that right? Yes. So I'm not discussing that exposure part and all that. So we'll begin first and foremost with where we have reached, the bone. Okay. So there are two schools of thought. Few do femur first, few do tibia first. So I personally like to go with femur first. What about you, sir?
there is a common saying that you have one wife and many girlfriends. So in tibia you have to take one axis. So it is your wife. And in femur so many axes to take
Yes.
the. So one wife, many girlfriends. Sorry for the ladies, but this is what. So I do personally femur first. That is just because that once you cut the femur, tibia is subluxated easily.
Yes.
Aja, hello,
It's easier as well to have the tibia out and delivered and exposed in front. So
So just sorry, I would also like to introduce Dr. Alok Kumar Singh. He is a consultant orthopedic surgeon, very trained, and he is presently in Jharkhand, Bokaro city. He is working with one of the big corporates there. He'll also be there. So I'll just be aside. So tibia is like your wife, and femur is like your girlfriend. Do whatever you want, but do it right. I welcome Dr. Ashok sir.
So as sir said, yes, uh, I've been very flexible. I started doing tibia first when I was getting trained. Then I moved on to doing femur first. But right now I'm very flexible. If I have a very fatty patient or a high BMI patient, what I do is I prefer to cut femur first because that gives a good exposure to tibia. When I don't have to keep on revising the corners and all that. So first and foremost, I go with femur. We are going to do a conventional. We are not doing any navigated or robotics. So we make use of the jigs. So we are using striker. Ravi is there. He is going to help us. So we are going to aim for mechanical alignment. We want to get both the surfaces parallel to each other. We are not going to go into kinematics and all that, kinematic alignment and all that. So we are going to drill. We are going to start making a hole which is just superior to the intercondylar notch. If you put it a bit medial or a lateral, I hope so I'm right. So we put in a line, there are different kind of systems. I think I nibble it off the cartilage if there is remnant in that area. Then I use a punch to create a hole, and then I gently put in my alignment rod in the femoral shaft. So that's it. Well, while putting the rod, be a bit gentle. Don't suddenly pull it in, because those patients who especially have comorbidities, there are chances of embolism and all that happening. If there is a porotic bone, you can fracture it as well. So be gentle while many a times you have your assistants or personals, company personals who put in. Always try to put the alignment rod by yourself. So this is going to give you the anatomical axis of the femur. So on the top of it, place your,
Alignment that you have to put with drill or hand?
no, you have to put it by hand. It's not a very wide rod. The canals are usually porotic and wide only. So you don't need to put in a drill. You just have to open it up over here. So yes, yes, you have an entry reamer. Do you have entry drill? Yes, this is the entry drill. In striker it's good. It has a very sharp tip, you can see. So it can create the space by itself. But there are a few companies where it's not that pointed. So I nibble it off. I put in a very small osteotome in a cruciate fashion. I rotate it up and then I put it in. So I don't go, yes. Yes, yes. Then at times you may, your drill may skew off. You may go in the notch or up or something like that. So I always open it up and then I put in this drill, and then there are few drills which are wide on the top, graduated. There are few which are very narrow. So at times you have to go like this, but you are pointed like this. So when you're drilling, be gentle, and then you can as well widen the hole as well. So
Point depend upon the valgus of the knee.
uh,
Whether if the valgus is to more like 7 degree or 9 degree.
it can go a bit lateral or medial, 5 mm medial or lateral, but usually it's off center. And like I say, if you are going to do a unicondylar knee, it's going to be a bit different. If you are going to do a routine TKR. So once you are in a right position, it's going to take its path. It's not going to skew off a lot. So I put in my alignment rod. I put in, yes, since we are calculating our anatomical axis. So we are going to take our cut in such a way so that we are going to get a, yes, mechanical axis. So usually what funda is, we have learned that we have to put it in 5 degree of, yes, valgus. So this is what we place, but when we are going to discuss robotics and navigation, this is where these things change. The didactic values on jigs. It's not always 5 degree for everyone. The rotation is not always 3 degree for everyone. The slope is not always 3 degree or 7 degree or 5 degree for everyone. This is where things change. We say, nah, 20% of patients are not happy. It's because, yes, we have been taught that these fixed values stay same for everyone, and that's not the case. I think I'm right. If you want to add, please do add. So for now, yes, we are considering this as a routine knee. We are going to take a 5 degree valgus. So while putting in this, you will have to always check your side. Yes, verify your side whether it's right or left, and the angle which you want to dial, whether it's 5 degree, 6 degree, 7 degree or whatever. Navigation helps, but it's not that you always need to use a navigation to know or a robotic to know. If you draw your axes, you will, yes, long length films, you get a CT done, you will conventionally know all you tell your radiologist to tell me all the angles, they will let you know all the angles. So,
Valgus knee, do you decrease the angles or do you?
yes, of course, if you, at times, if you will place in 5 degree valgus, and you will end up seeing that you're not getting any cut, yes. And more so, valgus knee is a different pathology than varus knee. You cannot dial your rotations and everything basis on the basis of how you do in a varus knee. And that's why a valgus knee is a little more challenging as compared to varus knee. So after we put this in, we'll have to gently tap it in. Do we have a hammer? So that it is flush with the condyles. It doesn't normally sit on both condyles. The highest condyle, whatever it is, it sits. Do you have a mallet? Achha, we don't have to put it in. Huh? Yes. Now every implant has a fixed resection. 8 mm in striker, I think, 9 mm in Merrill, something like that. So I have dialed in my valgus angle, and I now put in my resection jig for distal femur. We are going to take a distal femur cut first. As sir said, there are less chances to go wrong here. Why? Because your alignment rod is already in. Okay, here we are, most of the times we are not using an intramedullary jig, we are using an extramedullary, yes. So the eyeballing, 2 degree, 3 degree, 4, we can go wrong in that, but there are less chances that will go wrong here as far as a simple straight case is posted. So this has to be sitting flush on the tibial on the femoral condyles, either of the femoral condyles. side check, angle check, and then you put in your resection jig, distal femoral resection jig. Okay? Yes, we have to. I mean, I have gone beyond the approaches, remove the osteophytes, clear off the fat pad area, fat here, expose everything well. You can also remove osteophytes in alongside the condyles, below the MCLs and all that. So, approach thing, yes. It has to be sitting flush, and then you put in your pins. We put in pins in 0 and 0 first. We can drill or we can mallet, whatever it is. इसी से कर ले. I hope it's pre-drilled. Always try to drill in instead of hammering in. Because as we say, we are discussing a game of 1 or 2 degrees, so it changes. अगर ये उठा हुआ है और मैं इसको जबरदस्ती पुश इन कर देता हूँ, तो that changes my slope and lots of things.
If it was sclerotic knee, you have to first drill, then you can put the pin.
Make it a habit to drill gradually. If you as you keep on doing cases, you can decide what to do when. So we put it in. We have put in the pins. And now we'll take the alignment rod out. Where we can. So this basically means that we have placed our distal cutting block in 5-degree valgus, and the jig is placed in such a way that it's going to cut 8 mm of bone from the highest point. So before taking the cut, always check with your angel wing, yes, whether your depth of cut is accurate. At times it malaligns, you end up taking more resection. It's always good to err on lesser side in comparison to higher side. You can always revise to a higher resection level in comparison to lower ones. So always check whether your cut is going to be accurate. You are not going to take an extra cut. So after that, I tend to place in my cross pins, so that your jig doesn't wobble, doesn't move, doesn't back out. Yes. So secure it on both sides, at least as far as osteoporotic bones are concerned. Take in your saw, place your retractor saw over both sides of ligament. Yes. Protect your MCL. Yes. As well as your LCL. Yes, and the way of putting in retractors here at this stage is at least such a way that you are not focused more towards tibial condyles, but towards femoral condyle. It can go in, it can slide in nicely behind the condyles. It's going to give a posterior protection as well. And then we'll take in a saw and we'll take a cut. We have a saw. So we don't have a saw, so we are going to chip it off. We'll try with osteotome. Let's see. It's easier to actually cut a bone than a saw in reality. Always ask for a new blade. Another tip, don't settle in for old blades. We do at times, but yes, but you should always ask for a new blade. You want to take a cut? It's as simple. Yeah, you can cut. So, yes. Always use a protection. Just a moment. Yes. You have to place an osteotome. You can flex your knee a bit more so that your condyle comes up in the air, so that you are not going to hit tibia more. Yes, thank you. So you can take in a cut. Yes. Yes. Yes, so Wait a minute. So you are hitting the pins now. So yes, you can rotate your saw blade. Yes.
रोटेट आपका नहीं होता है.
Fix वाला है. Striker वाला होता है. Yes. Yes. Now, when you rotate your blades or you rotate your angles, the skiving of your blade happens as well. So yes, so you can change, that thing itself can change your slope and flexion of femoral component. So you have to be aware about that as well. So at times you keep on going, you change it and you will take a mm more, then a mm more. So you'll have to cross verify, yes, if everything is all right, I have taken a parallel, I have taken a good cut. So we routinely do that. Okay? So your distal femoral cut is done. Yes. I'll take my cross pins out. I'll leave my, yes.
I will assess this cut is adequate or not, whether I have gone, is there any?
One thing is eyeballing, second thing is I pass in my angel wing from the opposite side and see if my resection is nice.
Shape is also.
Yes, that the cut thing will come out. It will just take a bit mm of your notch and it will be just like a wing of a butterfly. When you cut it proximally, it will be like a piano shape. So it will be just at the level intercondylar notch. 1 mm or 2 mm, just connecting the two condylar resected areas. So this thing is out. We have taken distal femur. This thing is out. We have taken the distal femoral resection block out. I leave the pins in case I need to reassess and revise my this thing. Yes. So now we are going to come to our proximal tibial cut. So again exposure, place in your Homan behind. You have a blunt Homan so that you don't, yes, you have a 90 degree, yes. So you don't injure your posterior structures, yes. So now we are going, here we used an intramedullary alignment rod, here we do an extramedullary. It's not that you can't use an intramedullary here as well, there are many people who do. But the thing is that how we have been traditionally trained, we take in a extramedullary alignment here. So can we have our extramedullary tibial alignment jig? So it's supposed to be placed at the level of ankle, and then as sir said, there are 3 axes which you have to see here. You have to see, we can leave it here because we know that there is nothing behind. 3 axes have to be seen here. Number 1 is your varus and valgus. So we know our outliers. Traditional studies, 3 degree varus, 3 degree valgus, you are all right. So you have to aim that you are in that right plane. Apart from that, varus valgus, the depth of resection, again 8 mm I think, or 9 mm? 9 mm here. And last, your slope. Slope is very important. If you reverse your slope, you know you are going to struggle in your flexions. If you have a very high slope, you know you are going to struggle in your terminal extension because it's going to act as a block. So your slope, didacted by many implant manufacturers, few recommend 3 degrees. Then there is on one domain Zimmer which says 7 degrees. So you have to configure that out, what is working best in your hand, but yes, you will have to stick to your recommended guidelines as well. So yes, how do you align? How do you prefer to align this alignment rod? Thin patients, feel for your shin of tibia. Even fatty patients, you can always feel your tuberosity. You can always make a note of your tibial spine, the medial border and the lateral border. Okay, the basic concept is the implant placement should be in such a manner that it's bisecting your tibial tuberosity in medial 1/3 and lateral 2/3. And your alignment rod, if it's perpendicular to your shin bone, a bit center of ankle or a little off center more towards medial. Never look towards toes. Why? They are mobile. And many a times they are deformed as well in old patients. So we have a common habit of seeing the toes ki first or second web space ke beech mein ja raha. Nahi. That's not right. Yes. Yes. There are people who don't even place this alignment rod. They put in directly. I think they do it in Gujarat. Yes. So they know that I have to put it in this way and this is going to do my job well. So that maybe you'll learn with time. But for now, yes, your shin, your tibial tuberosity, your ankle, they are a very good guide. Okay. अगर आप इसको अब ये है ना, आप तीनों एक्सेस दिखा दो. यस, ये फिक्स है शायद. हाँ, यहाँ से प्रेस करके. यस, yes. So this is going to change your valgus. You can see na, this is tilting your cutting block, tibial cutting block like this and this. So you can medialize or you can lateralize as per your needs. Acha ye.
Medialize, when to lateralize, when to be central. Is there any
That again I said, if you have a straightforward normal varus knee like you get in US early presentation, I think you can go that 1/3 and 2/3 concept. But you have an extreme varus knee or a valgus knee, then you'll have to alter your this thing. But the main aim in mechanical access as far as is concerned is to get it in the center and tibial shin and tibial tuberosity. So you cannot err much in this. But when you're going for aiming for kinematic alignment, yes, you can err.
generally we used to keep 0 degree, neither valgus nor vessel.
Yes, normal is 0 degree. Normal aim is to be on 0 degree or be a degree or two this side or that side. That's acceptable in when you're doing it conventionally. 3 degree is what they say in papers, but then the other papers who have denounced that thing, they say they have gone till 7 degrees as well. They have kept the component in varus as well, and they have had good results. There are few papers which say that they have had catastrophic polyethylene wear when they kept a functional alignment. So it's something to ponder. We have never reached a conclusion. But since we are doing a mechanical alignment, the aim is to put it in 0. 0. We have to have this thing in 5 degree valgus so that it comes to 0 mechanically, and we have to have this thing in 0 as well.
Then only it will be parallel.
Yes.
Rectangle, we have to create a rectangular block.
Yes, we have to put in a rectangular block in flexion as well as extension. So
Now fix the 3 degree slope. Now fix the 3 degree slope. If you want to increase the
yes, slope is up and down. You can see. Yes. Inclination. It changes your inclination of cutting block. Medial and lateralization of distally at this point changes your varus and valgus angulation. And last, height. Height is adjustable like this. Okay. So we have hammered in. There are 2 pins. One allows you to fix at the tibial spine, and then the other allows you to rotate. Okay. So this is also very well important because you have to aim to hit medial 1/3 and lateral 2/3. Yes. So he has hammered it in, secured at the position we wanted. Ankle is fixed. My angle of slope is fixed. My varus valgus is good. Now you have to assess your depth of resection. यहाँ पे ये this is there is a spring type structure, so you have to press it in. So you can take your measurements from good condyle or the bad condyle.
The lateral side is good, so we can take it from the lateral.
Yes. So this is higher point. You have to take 2 mm, I suppose, from here.
healthy corner from 9 and associate 2.
Hi, sorry. Yes. From this side we take 2, yeah, and this side we take 9. Okay. If you end up taking 9 from here, you're going to resect a lot here. So
Left side
that.
medial हो गई है.
Yes, but at times I'll tell again, if your approach is not very good, you may struggle to approach stylus over here, your stylus over lateral condyle, then you'll have to consider your medial condyle.
Sometimes in exposure we do not use to expose completely the condyles. So what is tricks to have complete exposure of
Good to
condyles?
expose the lateral.
Yes, so what I do is, what comes in between is the patellar fat pad actually. So whenever I avert the patella, and it's very easy, you can put in an artery between your tendon and fat pad. I've always done that. If this is my patella, if I have everted it out, there's a fat pad, I put in an artery and this thing, and then I run cautery over it. I know my tendon is safe. My entire fat pad comes out as one unit. You expose up your your meniscus and everything, and it's very easy to access even the posterior lateral corner that way. So put in an artery. If I can show, I can.
Good to remove all the fat pad or
Not actually the case.
amount.
I learned from a surgeon who used to remove everything, and everybody used to say that he has bared everything over the pedal. There's no cloth removed over it. But no, you should remove something so that that microvasculature penetration and everything, so that you have a good exposure of your condyles.
maybe ना जो पटिला क्लंक सिंड्रोम जो बोलते हैं ना वो होने का डर रहता है, इसलिए फैट पैड हटा देते हैं.
पटला क्लंक यहीं पे भी नहीं होता है, ऊपर भी होता है. yes, it's going to happen more over the quadriceps tendon and that fat area rather than the patellar tendon area. So we have placed in this thing, cutting block, 9 mm. So I'm happy with my slope.
8 है,
9.
9 है, ऊपर 8 है.
आप इसको चेंज भी कर सकते हैं, ऐसा नहीं है. I think there you can change, you can, you after anesthesia always check your knee whether it is hard, if there is no mobility in it, or whether it's loose. If you have a loose knee, always err on the lesser side, always take a lesser cut, because after you take resection, it's going to be more.
Take a lesser cut.
Yes. So you can take a 7 mm as well in that case. There's no rule that you have to take 9 and 9 only. At times you take 9 and you end up with a higher insert. Yes. So 14 mm, 17 mm insert चला जाता है. So you see whether your knee is lax or your knee is loose. Your knee is tight. You take out osteophytes, वो gap खुल जाएगा पूरा. So that changes. So
Starting each and every step, you should reassess your
yes. So I have placed in my stylus. I'm happy with my resection depth, slope, as well as varus valgus. So I'm going to put in my pins.
So you want to see.
Yes. Again, इसका cutting block ऊपर वाला.
इसके बाद सर ऐसे भी आप रख के check.
ठीक है, ऐसे भी आप रख के देख सकते हैं. What is the level of resection you are doing? अब जैसे ये है लग रहा है कि बहुत ज़्यादा है, ठीक है ना? Your resection should be such that it just takes a sliver from the medial aspect, ठीक है ना? Not more, not less. Okay? So yes, we saw here. We can take this. Yes. Every cutting block has mota-moti 3 level of holes. One is your neutral 0 and 0. Another is -2 and +2. Few have +4 as well. So that's going to help you revise if you want to increase your resection or decrease your resection. So we have placed in our 2 supporting pins. We are going to take out the extra articular jig, alignment rod. Yes. Yes. इसको निकालते समय थोड़ा be aware. You can hit your fingers. I have hit my fingers in past. So ऊपर से निकालिए, नहीं कि यहाँ से, ठीक है? So place in your cutting attachment. Place in your cross pins. अब इसमें मैं ये बोल रहा था, when you push it from here to here, it does change your slope a bit. So एक होता है ना कि you place in your pin hard और वो उसको ऐसे कर देता है, तो it skews off. वो ऐसे कर देता है या ऐसे कर देता है. That's going to change your slope. So be gentle at placing cross pins as well.
Cross का है.
हाँ, वो cross है. That is cross. Nice. So that is done. Now you have to place in your retractors on both the sides. वो हो गया, इधर भी हो गया. We'll take it for granted कि हमने लगा दिया है, ठीक है ना? अब now you can take in your cut. So it's good to have your tibia fully exposed at this point. I think that is called Ransal's maneuver. Yes, you take out, you deliver out the tibia, not take a cut in such a way that it. Yes. Ransal's maneuver is when you take out your tibia fully, posterior medial corner and everything.
This maneuver is to expose the tibia.
Expose the tibia, but then this again goes contrary to what we are doing today. In robotics, they say don't expose, especially in things like QVIS. It's going to mill. वो ऐसा bend होके then it goes and it mills on the corners. So they say that don't expose, don't harm the soft tissue. But classically, we have delivering out a tibia, balancing our posterior medial corner, and all that. Yes. Yes. So distal femoral cut taken, proximal tibial cut taken, do extension, check your gap. ठीक है ना? Whether you are happy, whether your ligament is tight on medial side, whether the knee is balanced or not. So place in your yes, you see whether your gap is adequate and balanced. It's not opening up in varus valgus and all that. If it is, first release your soft tissue. If it's not solving the problem again, maybe revise your cut, maybe you have hurt somewhere. So yes, then this step is done. You are happy, you can take out your pins. That's done. If you are not, then revise.
When we have to revise in extension gap, so where to revise, in the tibial side or femoral?
See, there is tibia side is going to change both your things. ये टिबिया है तो ये ऐसे भी चेंज करेगा और ये ऐसे भी चेंज करेगा. तो टिबिया, if you take a 2 mm cut, it's going to increase your flexion gap as well as extension gap. अगर आपको लग रहा है कि मेरा टाइट है in extension and my knee is a bit of flexion, I'll resect distal femur rather than doing proximal tibia. Why? Because this is going to change only extension. Yes, but this is going to change extension as well as flexion. So उसके लिए एक algorithm, एक chart है which says what to do and what not to do. But it is a simple common thinking कि इससे केवल ये check होएगा, लेकिन अगर ये हो गया तो दोनों change होएगा. Yes.
If the flexion gap both are tight, then you have to cut tibia.
And this maneuver, what was you are telling, is just to expose. When it's just
Ransal's maneuver is basically exposing, releasing posterior medial corner, removing all the osteophytes and delivering the tibia completely out. It's like, I cannot do here, yes.
it's a surgical.
Yes. But then things change every 10-20 years in our field. They say you don't, I don't know. Now, distal femur done, we are going to go for posterior femoral cut. So we are going to assess our rotation. इसके लिए मैं बात कर रहा था. Striker has a very good jig for rotation. Why? You can dial in your degrees. There are many jigs where you have a fixed value, 3 degree, 6 degree, 5 degree. ऐसे है. So if you can assess your rotation, अभी for now we'll go with 3 degrees, which is routinely and commonly done. But if you feel that you put in your distractor and you feel कि मेरा medial tight है, you can increase distal femoral resection. You can change your angle from 3 degree to maybe 4.5 degree or something like that. So again, flex a bit so that your condyles come up in air. You have to place in your posterior femoral alignment component in such a way that it's touching both the condyles. ठीक है ना? We are taking posterior condylar reference here. I haven't drawn white sides line. I haven't because this is what everybody does commonly and fastly. ठीक है? But yes, you should have a habit of drawing your white sides line. You should take your cutting block, put it in. You should take in your spacer, put it parallel, and see, draw your line and match. Especially in valgus knee, you should double verify whether you are doing right or not, because your rotation is going to be, because your lateral condyle is affected, it's going to be like this. So you are going to have a wrong distal femoral cut, and that's why valgus knee fail. So I have placed in my condyles. Okay, they are touching, both the prongs are touching the back of the posterior this thing, and now you are going to place in. Yes, कितना पे है? Side check.
3 degree left side.
3 degree left side. It's done. So we have considered it 3 degree, and yes, and left side. At times it has happened that people have done left ka right and right ka left. Rarely does, but because there is a lot of cross check, but it has happened. So now we know, and now we are going to do sizing of our femur. We are placed in our rotation. आप देख रहे हैं ना कि medial condyle ऊपर है, pin lateral condyle नीचे है. ये ज़्यादा बड़ा है medial condyle, so it's going to give me a parallel cut, kind of a parallel cut, so that I get a box and not a trapezoid or something like that. So this is for sizing. Different sizes हैं. All manufacturers have different sizes. Earlier they were extrapolated by data from abroad, but I think they have a lot of data from Indian femoral anatomy and tibial anatomy, and they are more conforming right now to the Indian population. So which is the higher of the two sides? The lateral side is higher of the two sides. So this is where we size. The component sizing is always done from the lateral cortex, femoral cortex. So it's going to hit here and be more on the conservative side. Be a bit higher than bit lower, because you are going to notch your proximal femur. So size क्या आ रहा है? You can see over here. It's 2 and 3. So what you will do? If you have a size like say 3, then yes, I'm happy, I'm going to go for 3. But you have 2 and 3. What are you going to do? Yes. Again, assess where your knee is tight or loose. If it's tight, I'll maybe go for a smaller size. But to begin with, I think we should always go with a higher, because you can, yes, you can do less cut and then you can again go for a higher cut. You can revise it to a lower size. But you do it in a lower size, you get in the bigger this thing, that's going to be a challenge. So 2 and 3 के बीच में I consider my knee to be a normal, not very tight, not very loose. I am going to go with a 3 cutting block. Okay, so I am going to take this out. हाँ, 3. So ये 3 यहाँ पे है. So I again put in my angel wing and I see whether I am notching or not. I am not notching. I am a bit happy. But इसमें again you will have to see where your saw is skiving. अगर मैं इसको ऐसे फ्लेक्शन में लेके चला लूंगा तो हो सकता है ये स्काइव कर जाएगा. तो बी अ बिट अवेयर दैट मेरा थोड़ा सा स्काइविंग अप होएगा, सो आई एम नॉट गोइंग टू डू अ लॉट ऑफ डैमेज. एंड दिस इज नॉट अ लॉट, मे बी अ डिग्री और 2. आप उतना ज्यादा जिग में उतना प्ले नहीं होता है कि यू कैन डू मोर देन दैट. सो हैप्पी विद दिस थिंग, हैप्पी विद द साइज, हैप्पी विद दिस थिंग. अगेन वन वे वेयर यू कैन वेरीफाई वेदर योर 3 साइज इज नॉट गोइंग टू बी अ लॉट बिग. मेरे को एक ट्रायल दे देना. से दिस इज 3, दिस इज 2, 3, 1. So 2 है, I can, हाँ आप निकाल लो उसको. There are few systems where you don't have to take out these pins, उसी के ऊपर cutting block लग जाता है. Then in here you will have to take it out and then punch in your cutting block, 4-in-1 block in that same hole. Reverse पे pin puller. Yes. So you can always verify कि 3 कहीं बड़ा तो नहीं हो जाएगा, 2 बहुत छोटा तो नहीं हो जाएगा. तो always put in my trial. Okay. This is 2. तो मेरे को दिख रहा है कि coverage is good and maybe I could have gone with 3 as well. ये 3 है. This is 3. So I see. Yes, 3 is good. ठीक है ना? Overhang नहीं करना चाहिए. More so even if you have a thing कि मेरे को in between number overhang हो सकता है, तो are more on the lateral side. Medial side पे नहीं होना चाहिए. It's more painful. It should not, overhang should not be there, should not be, that concept should not be there.
थोड़ा छोटा रहे चलेगा लेकिन ओवरहैंग नहीं होना चाहिए.
नहीं होना चाहिए, but usually इतना छोटा होता नहीं है. But even if you have to err on overhanging, be on the lateral side. Yes, cutting block. Do you have a cutting block?
लेटरल साइड इन एवरी सर्कमस्टेंसेस की वाल्गस वेरसनी में डिफरेंस हो जाता है. वेरसनी में मीडियल साइड में नहीं होना चाहिए ड्यू टू द टाइट स्ट्रक्चर है.
ऐसा नहीं है. Then you are going to balance your knee out, ना. Of course it is more tight on the. The thing is that ना medial जो collateral ligament है, that is going attached to your medial tibial shin and meniscus से attached. Okay, so it's very close to your this thing, to the bone. But your lateral collateral ligament is going to attach on the fibula. There is some play between your ligament and the bone. So there is some play available here, but that's not the case here. अगर वो हल्का सा भी 2 mm भी overhang होएगा, तो it's going to impinge your MCL. So it can cause attritional pain, attritional wear and tear, attritional.
Irrespective of valgus or varus नहीं.
Yes, valgus हो या varus हो, at the end of the day we are going to get a rectangular block and we have to balance it out. So it's not that कि in that case we can overhang here and that case overhang there. It should not overhang first and foremost. If it has to overhang, be on more on the lateral side. कटिंग ब्लॉक नहीं है तो हम 2 से ही कर लेंगे, नो इश्यूज. 2 का कर दो. सो यस, अब इनमें ये है सिस्टम कि यू हैव टू पुट इन दिस इन द सेम होल्स एंड देयर आर अदर सिस्टम्स लाइक सेट एपीयू वेयर वो पिन के ऊपर ही चला जाता है.
So before putting this, we can reassess whether it is coming rectangular or not.
हाँ, yeah, yes.
Eyeballing से भी
Yes. Even after you put this thing in, तब भी आप देख लीजिएगा कि yes, this surface cutting is coming parallel to this or not.
बीच में ब्लॉक डाल के फ्लेक्शन गैप पे चेक.
Yes, you can always do that. So put in the cross pins. Should be sitting flush. Same here. Yes. सॉ है थोड़ा सा. Yes. So it has to be sitting flush. जैसे ये अभी थोड़ा सा फ्लेक्शन में है, सॉरी एक्सटेंशन में है, but it has to be sitting flush. Okay. And take in your angel wing again verify कि I'm not going to notch my femur. Okay. There are 2 kinds of referencing system. One is AR and one is PR. This is PR system. So PR में we have to take posterior referencing. We have to take care of anterior notching. And when you are doing an anterior referencing, उसमें थोड़ा सा you have to be aware about rotation first and foremost. At times you can go vary in your rotation. And second thing is you have to see whether you are cutting a lot of posterior condyle, because that is going to affect your posterior offset. फिर आपको rotation, your posterior component is going to be a bit loose if you resect up a bit more. But by a rule we do PR. I think 90% of places you will get a posterior referencing implant only, except until unless you ask for an AR implant. Yes. हो गया ना? I think yes, we can do. We can finish it off. नहीं? उसी को कर लेते हैं. हाँ. Yes. I think we are running short of time. You already delayed. Yes. Take the cut. Again, put in your retractors. Take anterior cut first. Yes, you have not notched, and the sign which you are asking, grand piano sign, you can see it's like जो old pianos होते थे wooden, उसे you can see you have not notched. That's great. So we are happy. Then I don't take anterior chamfer first because I want everything to be stable for posterior cut first. So I place in my this thing. Yes, if somebody can hold. Yes, and here as well. Yes. Straighten. Yes, you have to protect both your MCL and LCL. Yes.
To protect the posterior neurovascular.
Yes, of course you will have to have a control on your saw. You don't have to plunge it in, and always direct your saw away from the center. Yes, a bit more on the lateral aspect. Yes, it's done. You'll get a feel of it. Gradually as you do your case.
And you have a maximum flexion of this. And you end up this maneuver.
During posterior you have to keep it parallel, but when you are taking chamfer, then you'll have to put in maximal flexion so that it doesn't hit your tibia. So anterior chamfer cut. Yes, nicely done. And posterior chamfer. So here I flex in a bit more so that I get my condyles up in air, and then I place in my protection so that I don't hit tibia. Where is the artery? Where is the popliteal artery? Is it in center, more medial, or more lateral? Those of you who do arthroscopy will say better, I suppose. It's not medial, it's a bit off lateral. So when you're doing a lateral condyle posterior horn repair, there's a maximum chance where it's chance that you'll hit your popliteal artery. I always put in like saw like this or this. But when you have to consider this thing, so it's more towards your posterior horn of lateral meniscus. A bit more towards the lateral side. Yes, I think we'll. Yes, we can take this out. I'll ask Ashish sir, if you switch sides when you're doing right and left, you don't, you are used to. I'm
on the same side.
You're always on the same side. So, I don't know, I have not been able to imbibe that. At times I like to come up and take a cut rather than be on the opposite side. So Ravi keeps telling me, कि sir आप इधर उधर घूमते रहते हो table पे. So I keep a wide boundary across my table so that
360 view is better.
So you take this out, always use your punching system and not like this, because at times if your bone is porotic, it can chip off. So now done, your posterior femoral cut is done. What? Yes. Yes. Anterior cut, posterior cut, anterior chamfer, posterior chamfer. Yes. Yes. So now we are going to get, I assess my gap again. I put in my spacer and see whether my flexion gap is adequate. So yes. So यहाँ पे tight है, but इधर PCL भी intact है. So it has to go if you are doing a PS knee. So we check in again. We do a box cut, place in our implant. Those who want to do box cut, we can do very fast. I think we are running out of time. We are a bit delayed. So again, see your medialization, lateralization. Always make note of a osteophyte here. यहाँ पे osteophyte होता है in a medial varus knee. That relaxes your MCL again. So place in your pin. अब यहाँ पे you can err on flexion Sorry, extension and flexion. I think it's more good to err on flexion rather than extension. I'm right, sir? Yes. So place in your pin.
How to take out this posterior osteophytes?
Usually by the time you have taken your chamfer cuts now, a lot of your osteophytes will get loose, to be very frank, and they'll come out very easily. But at times if it's not, flex the knee, take in a curved osteotome, gently try to skive it off from the posterior aspect of this thing, and you will get most of the osteophytes. I also use a lamina spreader at times, so that it opens up and I get easy. So it has a very, Striker has a very good system. Instead of taking a direct cut, you can always, there is a system wherein you hammer in your, yes, you osteotomize your bone. So they recommend that you take a gentle bit of a cut and then hammer it in. I think it's not there in any other system. So it gives a bit of protection. But it gives,
Side cut.
yes, when you are taking cut on the walls,
Side cut.
all hammers are good. We don't differentiate on the basis of type of hammers. I think it's done. So that's it. You have to take this thing out and then you have a protection when you are taking side cuts. Yeah, place in your protection so that you don't damage your condyles. Yes, very nice. Take this out. Yes. So now you have your yes. You are in a position where you can do your trial. Place in your trial implant. Size 2 किया है ना हमने. We have done size 2. What's your take on downsizing and upsizing, sir? When you have an in-between number, it happens pretty frequently. Upsize, yes. Because as we discussed, it's always good to cut less and then revise to more. Yes, yes. Your assistant has to lift up your femur a bit and this, yes. Be gentle while hammering. Take care that you're not hammering in extension and you're not notching your this thing. जाओ जाओ कोई प्रॉब्लम नहीं है 100 है 100 में it's a bit more tougher than this thing थोड़ा lateral yes ऑर्थो वाला हाथ मारो फ्रैक्चर वाला नहीं बस ठीक है we'll accept this I think for us so you have done a wonderful job
We can accept little flexion, but not extension.
extension is going to give you a lot of trouble. I think when we are doing navigation robotics, I remember Rajesh, he said I'd always keep it in 3D flexion rather than putting it plumb. Yes, he is going posterior to anterior. वो थोड़ा है वो 100 के कारण है वो accept करो अभी but not in the case of course. So he is going to give a tibial trial. ज़्यादा फ्लेक्शन से दिक्कत होएगा आई थिंक एक्सटेंशन से होएगा यस आपका एक्सटेंशन आपका टाइट है बट आपने मैनेज कर लिया
100 बोने इसके लिए
यस यस so now check your range of motion see that you are attaining full extension full flexion whether you have any varus valgus instability whether you have a lift off this is like lifting off it means that there is some degree of tightness in posterior flexion or something. So you will have to balance your knee. A balanced knee is your happy patient. Unbalanced knee will also do well initially, but maybe after 5 years down the line, he is going to come back to you or 10 years down the line.
We have this sober session as well going on in one of the rooms.
Yes, sir.
FQ is also there.
Yes, sir.
FQ is also there.
So,
Wind up this session.
yes. And yes, thank you everyone. And if sir will like to add something, if something we have missed and how he does these things differently.
No, actually, nothing is done differently, first of all. It is done according to the protocol. So protocol means that you see everything very meticulously when you're doing the cuts. don't get distracted, protect the ligaments, because a happy knee is a combination of good bone cuts, less soft tissue release, and respect for the tissues actually. So learn serious instruments and don't get panicked when you're on the table.
Yes.
हो जाता है अच्छे से सब चीज़.
Yes.
अगर एक दो इम्प्लांट आगे पीछे हो तो मैं सुबह ही बोला कि यू कैन जस्ट अपने पैके पॉकेट से देने का. हिप
Yes.
में होता है, लगा दिया कप और वो फिट नहीं हो रहा है, कोई बात नहीं, सीमेंट लगाएंगे तो उसके पैसे हम देंगे, पर इम्प्लांट पे डरा देता है 40,000 का वेस्ट कर दिया. मैं लाखों का वेस्ट करता हूँ कभी कभी.
Yes. Don't compromise, at least in the beginning.
कभी नहीं,
Yes.
कभी भी होता है.
Be free to change sizes. And it's not that, I think they are also supportive in the beginning. They'll assess that your surgeon is doing his first case, so they'll help you out. So thank you everyone. Thank you sir. Thank you so much everyone for.
Sir, any
The
inputs from Dr. Anand Singh sir? कुछ बोलना चाहिए?
Thank you, every participants. I think learning has got no end, and you can keep on learning. Thank you very much.